There you go. And let them
And
all
we
in.
good to let everybody in. Alrighty. Celia, do you want to take the lead on my intro slides?
Either way is fine with me.
Yeah,
Put all the work into this, whatever you want to do.
no, that's okay. I'm happy to be in the background.
Are you getting a message about requesting access? I'm not sure what that is. I've not seen that before. Welcome,
LinkedIn.
everybody. We are so glad you're here. Today is Tuesday, if anybody forgot. My week feels like it's Friday already. But we are very excited to revisit our monthly virtual speaker series. We have an excellent speaker for you tonight, which we will get into. But we just want to say hello. Glad you're all here. We'll give everybody a minute to get settled, and we'll get started so that Kristen has the entirety of her time. I'm going to go ahead and advance the slide.
Alrighty.
So I think I've done the welcome and intro. I'm Celia Schlomer. For those of you who don't know me, I'm joined here by Lauren Bird. We both sit at the University of Cincinnati Center for Excellence in Developmental Disabilities, which sits in the Division for Developmental and Behavioral Pediatrics at Cincinnati Children's Hospital. We have landed here, and we've landed in the space of Rubinstein-Taybi support because Dr. Rubinstein started our division here at Cincinnati Children in that division of developmental and behavioral pediatrics. Tonight, we're going to be hearing from Kristen Turner, who is an OT therapist, and I'm not going to know what all those other ones mean, Kristen, so I'm going to let you talk about those. We're going to start with her and allow her to tell you all the beautiful things that she's going to share with you tonight, and then we'll follow up by questions and answers. If you have a question in the middle, put it in the chat. If it seems to be a question for clarity or for understanding of what Kristen is speaking in the moment, we will try to get her attentions and get that question to her. Otherwise, we'll save your questions for the end. But if you're anything like me, I forget what I wanted to ask. So feel free to put them in the chat so that you can hold space for them and move on and continue to listen. And then we'll wrap up. We ask that you please fill out our evaluations. It is what allows us to go back to our funders and tell them how much you appreciated the opportunity to have our speaker series so that we can ask for support to do it again. So that will come at the end. So we appreciate if you're willing to do that. Go ahead. So we are part of the USAID team, as I said, Lauren and myself, and Dr. Ilka Riddle, who I don't believe is with us this evening. And she is the director of our USAID. Is she here?
Mm-hmm.
Oh, well, hopefully she'll turn on her camera and wave if she can. But Dr. Ilka Riddle is, there she is. I see her little thing in the chat. She is our director. And we are part of, as I mentioned earlier, our University Center of Excellence. And the University Centers for Excellence are charged with doing interdisciplinary training across in each state, much as we are to have a state agency for disability. We also need to have one of these things called a Center for Excellence, and it encourages training and research. And ours has a very, very large focus on family support. Is there anything I forgot, Dr. Riddle? I'm hoping.
No, I think you did a beautiful job.
There you go.
Hello, everyone. Sorry, I can't get my camera on.
That's okay. All right. Thank you. Go ahead. So Kristen comes to us as an occupational therapist here at Cincinnati Children's. She has over 23 years of experience specializing in pediatric feeding and eating and swallowing disorders. Her clinical focus spans infant feeding, swallowing dysfunction, celiac support, and disordered eating, including RFID. She serves on multiple interdisciplinary teams here at Children's, and which also includes our feeding and celiac teams, and supports behavioral feeding treatment through our division of DDBP. As a leader in the outpatient OT competency training, she is dedicated to collaborative, individualized care that empowers families and improves outcomes. So with that, I'm going to hand it over to Kristen.
Unmute myself. Thank you so much. And thank you everyone for having me tonight. And those credentials are like everyone, we just love to put extra, so I'm gonna share my screen real quick. See if it works as well as it did in okay, do we have the right?
We're seeing yours, your presenter view now.
Oh my goodness. I practiced.
Okay. We did, we practiced. It's okay.
Let's try again. Hold on. Okay, now do you see? No, you see the full thing again, don't you?
We're not seeing anything yet.
No. Do you still see my presenter now?
You don't see anything yet.
No.
It's okay. Take your time.
So much for my practice round. Sorry, guys.
We did so well to practice, but those things just happen.
Did. And now you have my presenter mode.
I do.
Okay.
Okay. In the meantime, while you're doing that, folks, there you go. You did it.
Okay. Now let me see if I can get my presenter mode just for me.
Okay.
Yep. Fantastic.
Well, I don't have my presenter mode. I'm going to wing it, guys, but that's okay. I think I know the content well enough. So again, thank you for having me. I realized I needed to update my bio a little bit. I'm now on 25 years of practice as an OT. And the end credentials are specialty certification in feeding, eating, and swallowing from our OT department. So I'm very privileged to have the opportunity to get those credentials at the end. And so, like I said in my bio, I have worked in feeding for a long time, a little bit out of necessity. I was an early clinician in a very rural area of Indiana, going into families' homes and recognizing that families needed support in their feeding journey. And so I did a lot of self-teaching in several courses to try to really problem solve what families needed. And so that has brought me to my strong clinical practice now, just using a very broad, diverse knowledge and definitely different tools in my toolbox, I say, to support families, because every family has a different journey and every child has a different journey. And so I want to make sure that I'm able to support those families where they are. So my presentation today is a little broad, just to do some additional education. And again, I apologize, I'm not sure where everybody's coming from, but there is new information from a feeding standpoint. And I wanted to make sure everyone was aware of some of that and also start to have an understanding of how we get to our different areas. So again, want to understand risk factors associated with feeding in general, but also diagnosis specific, and understand the various roles based on where you are. There are going to be different individuals to support. In our community, we have the opportunity for both speech and OT support through Cincinnati Children's. We have a lot of overlap and a lot of collaboration, but that is not the case in all areas. When I was, in my early years in small rural Indiana, it was just me. Even the speech therapists in that area did not have those skills. So recognizing who your players might be and how they can support you. And then also looking at some of the evidence. Social media is just amazing for so many opportunities to connect, but it can also be a detriment if you're not really sure what you're looking at. And so we have found a lot of information that's not always in the best evidence-based strategies that families are starting to use. So here we are. This is what every family would love to see at every meal. When we first have our children, we're like, oh, I'm going to have this, and this is what it's going to look like, and it's going to be so joyous. And we see the multi-generations and the kids eating so nicely and all the colors and the different foods that are offered. We're also looking at the social aspects of feeding. Everyone's enjoying themselves. We have different smells and tastes and textures and sounds and appearances of those foods being presented. And then here's reality. Our kids come and they teach us a whole new aspect to feeding. And now, whether there's challenges or not challenges, sometimes those meal times can look a little chaotic. We had 3 kids under 3, and my husband are like, who's spilling the milk today? Because for sure there was going to be something that happened at the mealtime, something that happened at dinner. And then you add in any challenges with feeding, and man, that stress level of what can already be a stressful situation just really increases. So we want to look at a variety of different situations that have led us down this path, whether it's medical, whether there's those true oral structural challenges, which we know occur often, chewing and swallowing difficulties, even the smell, the look of food, the texture, the temperature, a lot of that sensory overwhelms children and adults for that matter. And then the stimuli in the background. If you have a sibling that's running around coming in from something while you're trying to feed this other child who has some challenges, that distraction is going to be huge. They've already forgotten about this meal, which they're not really interested in to begin with, while you have all of your time and effort committed to it. There's a TV, a sibling, a dad, whoever it is, walking in the background. So how did we get here and where do we go next? Again, every family's journey is different. I'm going to apologize, guys. I have lights that dim if you don't move. So I'm going to go turn those back on real quick. Hey, Todd. Todd. Really sorry. So I'm going to try this again, but I am going to see if my husband can make that not happen again. I was recording a presentation for UC one day, and halfway through the presentation, the lights kept going down too. I forgot about that until now. So how did we get here and where do we go next? So this is some information that may be new to some of you and may not. So there was a strong community of families and providers who were recognizing that, man, there is more to this feeding than what we just had as clinicians, as feeding difficulties or picky eating or whatever it may have been diagnosed by your provider. Sometimes it was just that they had Rubinstein-Taybi or that they had Down syndrome or autism or whatever it might be, but that didn't tell the full picture of where we were. So if anybody has heard of Feeding Matters, and if you haven't and have a child with some feeding challenges, 100% recommend looking more at the opportunities that they offer. But there was a collaborative group under Feeding Matters that got together and said, hey, we have more than just the diagnoses we currently have in our book. So pediatric feeding disorder is what came about with that collaboration. And again, I just want to make sure that families are aware, and sometimes it's helpful to say, oh, this is what this is. So it's when a child's eating or drinking differs from what is typical for their age. And that can look different for every child. It might be difficulties with variety of foods, with volume of foods, with true oral motor skills, or even their mealtime participation. What does that psychosocial aspect look like? This disorder may be short term. There was an event that happened, maybe a surgery, maybe a choking event, or it may be long-term and chronic. So we can look at it from different avenues as well. It is considered chronic if the symptoms last 3 months or longer. And what we know is that pediatric feeding disorder affects 1 in 37 children under the age of 5 in the US. That's a pretty significant number. And part of the reason for that is that we are looking at 4 domains for this pediatric feeding disorder. I'm going to quickly go through some of those domains to get a better understanding of what those are. So medical is our first one. Was there a health condition that makes feeding difficult? Medical causes of feeding issues, aspiration, when that fluid or food is going into the lungs, breathing problems, GI issues, whether it's reflux, constipation, genetic conditions, neurodevelopmental, or just differences in anatomy. And those can be from birth, or it can be that a child has developed difficulties with constipation or reflux or whatever, GI condition that arises. It can be that some children are premature and those feeding challenges came from the beginning, or that truly there were some anatomy challenges that made feeding difficult. Nutrition is our second domain, and that occurs when a child isn't getting the right nutrition or hydration. Sometimes they're not growing well enough, or sometimes it's too fast, and other times our weight is good, but because of those selective diets, the vitamins and minerals that they're receiving aren't enough to keep the body in a state of growth that it should be. Our feeding skills is our third domain. When a child has a problem with some of the sensory or motor functions needed for eating or drinking, they may require special equipment or feeding strategies. So if we have a skill deficit, there are some children that need an NG or a G tube to support that oral intake for growth. The other thing we can look at from a feeding skill is truly modifying. Do we need thickened liquids because our swallow is not what it needs to be and there's some risk of aspiration? Do we need changes in bite size or consistency? Is there different positioning or even equipment such as, changing nipple size or using special equipment for feeding, spoons, cups, whatever it might be? And then our psychosocial domain is our fourth one. And these include the behaviors and emotions that cause feeding difficulties. Again, if anyone's fed a 2-year-old, regardless of your 2-year-old, there's some behaviors and emotions that go along with that feeding. So we want to take into account that this might last past, what we deem typical for that age. And it could be truly a fear of eating, refusal to eat, or just that high stress during meal times. Sometimes it's that really selective feeding patterns that lead to stress or increase in behaviors when something different is presented. So you can have overlap in multiple domains, or you can have one domain in and of itself. So again, everyone has just a diverse community in which it supports their child. And so we do want to really make sure we have that true multidisciplinary evaluation, that we have GI, maybe allergy, potentially ENT for tonsils and adenoids or reflex barriers. So our pediatrician, whether developmental and behavioral or just your PCP, everyone plays a role in understanding the puzzle of feeding and nutrition. Of course, you have nutritionists and dietitians. Physical abilities can be through speech, OT, and we add PT in here. It is within a PT domain, although many PTs don't truly work on feeding, but positioning is so important. If you don't have proper positioning when you're trying to eat, it's really challenging. So our PTs play such a prime role in understanding, hey, how can we best support all of this other motor so that we only have to work on oral? Our OT is going to really look at those sensory concerns. I was working with a child today who had a quesadilla with some cheese in it, and left alone when that quesadilla went in the mouth, the quesadilla broke apart from the cheese, and he was really struggling from a sensory standpoint. But if we just melted that cheese a little bit, it kept the quesadilla together, and then it became one uniform piece. And then that was okay. So again, our foods that we eat change so rapidly once they're in our mouth. So really understanding that sensory from the look, the smell, the touch of it outside, but also once you get a food in your mouth, how is it changing? And what happens to that change? And understanding those dynamics will really help you support your children. And then of course, the feeding behaviors. We all have behaviors for a reason, whether they're old behaviors or whether they're new behaviors. They serve a purpose to us as individuals, but might not be functional for the situation in which we're in. So if you have a child that had a lot of medical complications, of course, they're going to have some barriers from behaviors when it comes to feeding because their journey wasn't that typical path. It wasn't that pleasant experience through all of their medical experiences. Sometimes those experiences were a lot of touch and feel and potentially tubes in their mouth, in their nose, whatever that might be. But that made maybe some aversions or some challenges associated with presenting some of the new foods. So again, I talked about some of these medical considerations and what we're looking for in the providers that might be part of that team. Whenever we're working on feeding, we always want to make sure, hey, everything medical checks out okay. I don't want to ever push a food that a child might actually truly have an allergy to, or might be causing additional reflux, or there's constipation. And if there's not room to get foods in due to the constipation, it's only going to hurt more. So always make sure that medically your child and the kids that you are working with have a solid foundation in which to move forward. So medical is always the first thing that we're going to look for. And then nutrition is our second. So we obviously want weight gain and growth, and we need to be really cognizant that we continue to support that from a therapeutic standpoint. So these slides were added. Unfortunately, I could not get a dietitian to join us today. I didn't have the opportunity. But I did have her look over these. So I'm going to ad-lib for her, but truly that adequacy of intake. So if we need intake, sometimes some of those behaviors get to just be what they are because our priority has to be getting some of that nutrition in, and we'll deal with the behaviors once we have that growth in nutrition. So that fat and muscle status are signs of that vitamin and mineral deficiencies. So a lot of our dietitians will do some measurements of the forearm, for instance, and really looking at your food log to say, okay, are we meeting the needs of all the vitamins and nutrients that are needed? And they're looking at mealtime behaviors as well. And I'll talk about this a little bit more, but when we look at mealtime, one of the things we want to know is that structure, because the structure can really start to impact our nutritional intake. So here is our My Plate. Back in the day, it was the food pyramid. So now we have My Plate, and yes, we're going to leave it at My Plate. That's what we like to have. So there are some changes coming up, but from a nutrition standpoint, My Plate still stands as the one to fall under. And so not only are we looking at the food groups, of course, that's always important, but there's also a reason why we have those food groups and why they are in the volume that we are seeing on the plate. So these are those nutrients that are brought in from our fruits and vegetables, for instance. From our grains, we're getting different things. From our proteins, again, more of those nutrients that we need. So if we have kids that are really strong on grains, because carbs are great to eat, they taste delicious, they're easy to manage, lots of kids like them, that's great. We're getting some of our nutrients, but not all of them. And then, of course, our dairy. So understanding from a nutrition standpoint, are we getting enough in each food group to meet those needs? So we've been taught for a long time, 3 food groups per meal, 2 per snack, trying to get those fruits and veggies in. And we try, every parent tries, and we're not always successful, but we certainly try. So the protein source, most snacks, I find proteins are mostly at dinner. So that's when we tend to have more of our meats, and our snacks tend to be more of our carbs. And then our dairy source is our milk, yogurts, cheese, cottage cheese at 3 of those meals and our snacks. So, and again, hydration is important, and bowel regularity. And I talked about this earlier. So it is very important to make sure constipation isn't one of our barriers. One of the biggest supports for constipation is hydration. But there are also lots of kids that don't prefer to drink, or at least not the volume that is needed in the day to really keep that going. So again, from nutrition, those fluids should be sugar-free, clear liquids as much as possible. Fruit juice for constipation, but less than 8 ounces per day. So then we get into what I know. Here's our oral motor and sensory considerations. So just things to think about during your journey. That swallow study, or a video swallow study, or a FEES are both tools to assess that swallow function. There's only so much we can see from clinical eyes. And so when I'm watching a child eat, I'm looking for those oral motor skills, and I'm listening. Is there coughing, choking, congestion that might make me think, man, something just doesn't feel right with the timing of that swallow? If that's the case, then I'm going to take a little bit closer look with some of those instrumental assessments. Again, our chewing, sucking, and swallowing assessment is going to be observation of different foods, of a puree, of a soft solid, of a crunchy solid, maybe a higher texture food like a meat if it's appropriate for that child. And how are they managing? How long does it take? What's that bite size? Are they holding? Whatever those patterns might be, I just want to see what that typical might look like. Self-feeding. We want our kids to have independence. And so looking at how can we support from a self-feeding standpoint when the time is right. Refusal, those behaviors that start to come in, are they sensory or are they behavioral, and understanding what those differences might look like. And then our food selectivity. We had a lot of brand specific children. The challenges become when we make a food at home, it is different the majority of the times that we make it. Even if you're taking a frozen chicken nugget and heating it up, it is going to be slightly different each time, versus fast food places have mastered consistency. That's what keeps people coming back, is that it is going to be the same every time. So children get brand specific, one, for the consistency of the foods and knowing that it's going to have that same texture, taste, and feel every time. And also, again, they start to limit, many children who are selective eaters start to limit what they're willing to take. And they do that by also putting different brands on. So one of the first things we want to consider is to truly understand what that mealtime routine looks like. It is very easy to fall into a pattern of feeding on demand when kids say they're hungry, how much they want, when they want, and what they want. If you have a child that has struggled with weight gain, you will do whatever it takes to make sure that we continue to get that weight gain. And some of that lends itself to patterns that we don't love, but this is how families are able to get it in. The challenge with meal times that are unstructured or at the child's desire is that not all kids have that hunger cue. And so I often think about our hunger drive like a gas tank. It's just an easy analogy for individuals to understand. We empty that gas tank, and I will say we, those of us who have a good hunger drive and understanding for mealtime, will empty that gas tank, and then we have a full meal. We fill it up, and then we are good to go for another 2.5 to 3 hours until we empty again. We have that hunger cue where the gas light goes on, we fill up, and we continue that cycle throughout the day. Kids that don't have those good intrinsic cues, one, it takes a long time for them to realize that gas light's on. Like we get the cue and our gas tank, has another 30 miles in it. These kids go 60 before they even realize that that light came on, that they need to eat. So a lot of times it'll take a lot. And then what happens if we get into this grazing pattern is that they'll fill a quarter of a tank, just enough for that light to go on. Or to go off, sorry, just enough for that light to go off and them to not have that hunger, sensation, but not enough to really fill to go to the next meal. So then you get quarter tank and empty, quarter tank and empty. So they're going to put a few crackers in their mouth here, a few pieces of cheese here, a little bit of milk here, but never really get that full. So that mealtime routine is meant to teach children and their bodies what that fill looks like and what that empty feels like. We want to identify those times for both solids and liquids. It is really easy to fill up on milk all day long, if that's what you have access to, for instance, and keep those sensations at bay. Identifying that day and night schedule, and this can be really challenging. So there are a lot of children that have feeding support through a feeding tube, and they might have a night schedule where that's where they're getting a lot of their nutrition. Well, if my gut is getting nutrition all night, a lot of times it just wants to rest during the day. So some families will come and they're like, oh, we feed at night so that they have that hunger cue during the day. But I have hunger cues at day and I rest all night. So we really have to think about, did we just reverse that cycle so that we're taking care of all of that during the night? But that doesn't always equate to hunger cues during the day because we've gotten the nutrition in that 24-hour period. They're just getting it at night. And then identify the length of meal times for both solids and liquids. We love a mealtime to not go over 30 minutes. Kids don't have the attention span past 30 minutes. So then you get a lot of picking and grazing and playing around. So you're not getting a whole lot of value for your time. And then also you don't have as much time to get that empty again before you're filling. If my meal goes for an hour and then I only have an hour before that next snack, I haven't really emptied what I had before. So it really starts to move into that grazing pattern. So number one for me, medical. Number two, establish a mealtime routine that I can then work from. Number three, we're looking at skills. So what are the suggestions for oral motor skills? And they are going to vary greatly per child and per family. I'm happy to answer questions if anyone has them at the end on this, because that does get a little bit more specific, but just some things to think about. And I would love to hear other families start thinking about, hey, during your journey, if you had a journey with some feeding challenges, what were things that worked? Because obviously you guys are a community for a reason, and sharing those resources is one of our best opportunities. So, and I always love to learn as well. So kind of the things we want to look at are lack of oral awareness. And so when I have a food in my mouth, do I know where it is? So if you put a food in your mouth, you have pretty good awareness of where it is. You push it over, you're chewing, you still know where it is. You're pulling it together, you're swallowing, you still know where it is. Several challenges that can happen with kids with lower muscle tone or oral motor deficits can be that they just lose awareness of that food. So I put it in there. Yeah, I knew where it was. I chewed it. Yeah, I knew where it was. And then suddenly, I don't know where it is anymore. It's still over here. It's chewed up, but I don't have that same awareness because it changed now. It went from a solid and now I broke it down and it sits. So we get a lot of holding in the mouth or storing or pocketing of foods. So one of the things that we can use as a strategy is to use more flavor. If I can keep flavor, when you put a pickle in your mouth, you know where that pickle is. When you put a carrot in your mouth, that's a different sensation because it doesn't have that same robust flavor that a pickle does. So understanding what that food offers is going to be super helpful. Your suckle pattern, and this is for infancy or lip closure on the spoon. So that suckle pattern is on the bottle. So we want to understand, where that placement is. Do kids have awareness? And then lip closure on the spoon. And that is truly just to start the sequence of a spoon is presented, my lips go down, I clear it off. Well, now I've already initiated what that swallow or what that oral movement is going to look like. And then our last one is difficulty with lateralization. So when I am moving to chew foods, I have to be able to take those foods, push them over to the side to my molar surface, chew them up, move them back, and swallow. So if I am stuck in this front to back pattern, we use a front to back pattern for bottles, and we use a front to back pattern for purees. So suddenly we have to learn how to lateralize and chew for those solids. So kids that are stuck in this front to back pattern are really going to struggle breaking down those higher texture foods and making that advancement from those early skills of puree, even some meltable solids, to more higher texture foods. So again, can we lateralize those foods? And if not, let's help out. Let's take a veggie straw is a great example of something that's a stick that I can hold over on those molar surfaces. I'm going to get the tongue coming over because it's like, oh, something's in my mouth. I'm going to get that munching pattern because it's a veggie straw and it's super delicious. Lots of salt, big flavor. And then it's also a meltable solid. So it's going to start to dissolve with my saliva alone. So that sequence helps kids manage that a little bit quicker. So just a great therapy strategy to start to work on some of those skills. And behavioral considerations. So when we look at that food selectivity and refusal, they're both behaviors. And often inadvertently over time, we fall into those, whether there were other things to consider, other kids in the house, other medical complications that we were really focused on. We are all caregivers, and it's challenging to encompass yourself in all of it. So sometimes you have to prioritize, even as caregivers, say, I'm going to focus on this right now. And yeah, I recognize that we're getting some of that food selectivity, but that can't be my focus right now. So that reinforcement of behaviors can become incompatible with the feeding. And so psychology is a great resource that we have on our team. And actually, when I was talking about my child with the quesadilla, I was actually working with psychology. And I was like, hey, this is what I'm seeing. And I think some of those refusal behaviors are because of that sensory. So once I changed it, she was able to get those foods in much easier. So again, that collaboration is so beneficial to best understand how to move forward. So behaviors can look different for every child. Do we have screaming or crying, tantrums, sometimes just leaving the table or not coming to the table? Aggression can happen, but usually I see that refusal to come to the table more. In some of our extreme cases, we get some self-injurious behaviors, refusing food, swatting, throwing it away, not getting it off the table. And you'll see a lot of that, especially from some of our younger kids, where they're just pushing, their head's turning and their hand is going, and they are really trying to tell you, hey, that's really challenging for me. Some kids will try the food and recognize there's a challenge and spit it out. And then vomiting can be one of the barriers. Vomiting can be challenging because we need to understand, hey, is that truly from a medical standpoint? Is there something going on that is causing or not supporting, but leading to this vomiting? Or is it just a behavioral reaction of, hey, I don't really like that. Look what I can do. And some kids start to vomit, not even because they want to. Sometimes that sensory response of I get a food in, I start gagging because sensory wise it's too much. And that gag lends to vomiting. And there are kids that I just call easy vomiters. And as soon as that gag response is triggered, they start vomiting. A lot of those kids had that early feeding journey that was a little more challenging. And maybe from a GI standpoint, they just tended to have a little bit more reflux or a little bit more vomiting as an infant. And that has kind of continued to be the body's response to some of that input. So things we really want to consider as we're making change. I've thrown a lot of at you. I'm like, okay, we have the medical, we have the mealtime, we have the oral motor. Now we threw in behaviors. You can't change it all at once. So what is the next best step that works for you, works for your child, and works for your family as a whole? And that's the community that your child is with as well. It's okay to say, okay, grandma's house, grandma does what grandma's going to do, because it is really hard to change grandmas. That's okay. But it is also helpful to understand that in that situation, I'm not going to push it. But in this situation, I am. But make it manageable for success. Every time we make a change, we want that change to be a success, or else we're just taking a step back. So what is that? Even if it feels small, what's that next manageable step? Choice of initial target food should be based on current repertoire likelihood of success. And what that means is, hey, what are foods that that child already likes? Can we change or tweak that food just a little bit? And these are for kids that are selective eaters, have a low variety of foods. Can we take those foods that they're currently accepting and change it just enough to be a new food? And there are lots of tools and resources out there in what we call food chaining, where you're just changing one characteristic of a food. For some kids, that tool works great. My husband did not fix my lights. Please pause. Sorry, he said it was not an easy fix. So, okay. So work on one food at a time. If you have a family meal time and you're like, I really want my child to try something that the family is having, pick one food, not all three of them, so that we always only have one new food that we're working on. Inform the child of the plan and follow through with expectations. So this doesn't work for every child. Depends on the age, on some of our understanding, but there is always a way to be concrete and concise about our expectations. So if somebody puts a new food in your plate and the expectation is that you eat it, but it is a food that is so foreign, you are just not going to be able to do it. But it's this big and it looks really hard. Instead, if somebody put something this big on your plate and it still looks really hard, but now I know there's only one bite and that's good. Or if I have the really big food and somebody says, hey, here's 3 coins. Every bite you put a coin in a jar, and then when the coins are gone, that food goes away. So again, these are ways to let the child know what the expectations are. So I work on one of 2 ways, either having a visual with a child. So if you are expecting bites, you have that visual of how many, or volume. There's only 2 bites on that plate to begin with, and that's kind of that visual of when that is done. So that's a great way to kind of set that expectation. Reinforce each step. Food is super motivating to me. Love it. Eat breakfast, think about what's for lunch. Eat lunch, think about what's for dinner. I just ate dinner, and let me tell you, there's going to be dessert. So that is internally motivating to me, but it's not to every child that has some feeding challenges. So if the food itself is not rewarding, what can we offer for their efforts that is rewarding? And it doesn't have to be anything big. I love Connect 4 when I'm working with kids on getting some volume in different foods. It's social. It only takes 2 of us. I can always stay in control of it. But every time they take a bite, or if not, if they're kissing and licking a food, if they're sensory exploring a food, man, they get that coin and they can put it in Connect 4. I'm not there to play the game. They just think every time they put it on top of, my red and their black goes on top, that they've won. But it's just a great way to stay engaged and give that reinforcement, because they worked so hard to do whatever it was with that food. And then don't try to step ahead. Don't move to the next step until the previous one is consistently successful. We don't want to live in any one area for too long. We want to keep kids moving along, but we don't want to jump steps if we don't have that foundation. So when I'm looking at some sensory or behavioral, I'm only making the smallest change. Small change, so we can have that success. Again, our goal is to be successful with each step that we move through. So those sensory sensitivities, that anxiety because they don't have any idea of what the food will look like or feel like when they're eating it, what's that taste? One of the things that I like to do with kids, and again, your children are at a variety of different ages and understanding. So throwing just a lot of tools out there. But if a child has that clear hesitancy to try new foods, clearly saying, that's gross, yuck, I'm not eating that, often that is cognitively decided, sometimes before they even see a food, but for sure before they've tasted a food. So one of the first things we need to do is change the language. So if that's gross and that's yuck and I'm not eating it are the first words you hear, I will have parents say, hey, let's talk about 3 things about that food. And you can give them ideas. Is it dry? Is it wet? Is it bumpy? Is it smooth? Is it red or is it green? So really concrete language, so they start looking at that food in a different way instead of immediately seeing it and saying that's gross. So how we're talking about and how we're learning about food is going to be really helpful. And that food may never go in the child's mouth, but let's just start with looking and learning about some of those properties that feel concrete. And ask, what can I do to help this child feel comfortable taking that bite of food? So again, sometimes we're not going to go right for a bite. Sometimes we're just picking it up and smelling it. If your child's reaction to a new food is running the other way, if I can get them to stay long enough to pick it up and give it a smell, hey, that's a win. That's that baby step in the right direction. So how can we back up to a point that there is success for that child and for you as the caregiver, to be honest, to have this experience around the food? So here are some of those approaches that we might use, and some of them I already talked about. So variety of different approaches for general feeding sensitivities. Teach that sensory exploration of food. Don't get stuck in play. When kids are young, they love to touch and they love to explore and they love to self-feed. Beautiful. Give them those opportunities. There comes a time when that exploration of foods is now them truly just picking it up and squeezing it. It had no intention of ever going in the mouth. So make sure that we offer those opportunities for sensory exploration. But when it gets to the point that you are like, oh man, I've got a mess to clean up, maybe we've gone far enough and we can take that food away, and that's okay. Children can easily learn that food is for play, and we want them to remember that food is for eating. So if they're having that sensory exploration, but not really great eaters, go up and give that a smell, bring model for the child what that next step might be. Our younger kids are sponges for modeling, and our older kids are sponges for play and engagement. So really look at where your child is in their developmental level to understand, hey, what is the next best step for me? So we're going to teach those properties of foods to help desensitize. Some are easier and some are harder. So if I look at a food hierarchy, taking a bite is way up here. Way down here, again, I might just look at it. I might smell it, touch it, kiss it, lick it, hold it in my teeth, not even taking a bite. Take a little bite, small mouse bite. It's going to be, sometimes I just call it the speck bite, because man, when you tell kids to take a small bite, they can like chisel off the smallest piece and you're like, did anything go in? We're going to reward it in the beginning because it was a step in the right direction, but the speck bite is really hard. And then the bites get bigger until we can chew and swallow. So there are lots of steps, and recognize, hey, that bite up here might not be the next best step. How can I back down to give that success? And feeding can still be fun. Again, I talked about the Connect 4. If you are using a reinforcer, make sure it's something that you still have control of. If I'm using Matchbox cars as a reinforcer and I give the child one for taking a bite, great. I don't want to have to take it away. And once I give them the second one, their hands are full and they're out. So make sure that the reinforcer lends itself to them wanting to come back. Mr. Potato Head is a great option, for instance. You can pick which eye. Should we put the feet on or the arm on? You have so many choices that you can give that child so that they stay engaged and want to finish that activity. And then address those internal feelings of full hungry by limiting that grazing. Again, everything goes back to, hey, we need that schedule, because if grazing and walking around with foods is how that child is eating, it doesn't matter how many new things I put in, all they know is to kind of walk away from food. So we want to have some sort of structure in which when I present a new food for whatever, level that child is at, they're still going to remain at the table. And then engage your child as much as you can. Identify preferred and new foods. Offer the choices and grading of the task to the just right challenge. And sometimes it might be, hey, should we kiss or lick? Giving that perceived sense of choice. Expand your child's knowledge versus I like that or I don't like that. Sometimes I'll put it in different ways, 1 to 5, was that a 1? I'm not really sure. A 5, that's my favorite food ever. So giving them the opportunity to rank foods versus an I like and I don't like. I don't like shouldn't be an option. It can be, I'm not sure about that yet, or, that's still new to me, or I need a few more times to try it. The research says 15 to 20 times to try a new food, and that can't be once a month for the next 20 months. That has to be pretty consecutive in presentation so that it's not new to that child every time. Nobody's really presenting green beans 15 days in a row because everyone would get tired of seeing it smashed on the plate. But it is helpful to know, hey, if there's a food that gained some interest, make sure you bring it back pretty quickly, because if not, it's going to be new all over again. And then again, use that concrete language of the color, the texture, the smell to describe. So not only is the child changing or hearing different language, you are also working on using different language. Things to remember when you're moving through: don't get stuck in one interaction with food. So as much as we say, hey, don't move forward till you mastered, make sure you recognize when you've gotten to that mastery and keep moving forward. we are all creatures of habit. And so once we get into a habit, it's really easy to stay in that place. So I'm going to take kissing, for instance. If you have a really selective child and you're working on that hierarchy of taking bites, a lot of kids are like, oh yeah, I got this kiss thing. Here it is. It's done. It's done. It's done. It's done. And then they're like, yep, moving on. So we've stayed too long in that. So keep pushing it forward and kind of recognizing whether as, a community, as your family, or with a professional, hey, we might need to move to that next step because we've mastered this one and we're kind of stuck here. Some kids just need to learn with new foods and feel comfortable enough to try them. I talked about food chaining earlier, and that food chaining is taking a food that child knows and making those small changes. The other concept and thought process is to say, hey, we're taking something totally new and we're going to explore that. This works a lot better, I have found, with some of my older kids that are so concrete in their food selectivity that they do not want to change that preferred food. That feels too much. But you can give them something totally different and they're like, okay, that's new and unique enough that I'm willing to explore that. So think about, again, what their comfort foods are and allow them to have some of those comfort foods. And sometimes those aren't the ones that you change. And consider how things look visually. Large volume of preferred with small volume of non-preferred. Sometimes as parents, we want to put this large portion on because we're like, man, we want this child to eat whatever it is. But when we see that large portion, when the child sees that large portion, they start to back away. They're like, too much. So think smaller and successful. Again, we are here to build and grow these healthy habits. And sometimes that means taking a step back and being like, okay, we're putting 3 pieces of that food with a larger volume of the preferred food so it doesn't feel so overwhelming. Here's some visual supports you can do, and I'm going to not skip through this slide, but there are social stories which are used for a variety of different situations, not just feeding, but it can be useful at the table as well. But these are some of the tools that we'll use, and here's some of the pictures for them. So earlier when we talked about setting expectations, these are ways to set the expectation. So if I have this number board, for instance, that's on the right, and maybe we're only doing 5 bites, I'm taking off 6 through 10, but every time a bite happens, we take off a number. And so the child knows when they are finished. The one on the very left is, I think that's which way you guys are looking at it. So sorry. That look, that touch, that smell, that holding teeth, that stir, scoop, those are all of the opportunities we have for the exploration of foods before we even get to bite. So if I have those visuals in front of me and maybe I just put touch and smell in front of the child and they get to pick, which one should we do? They're probably going to pick touch. So we touch the food, great, touch goes away. The next one might be smell or lick. Now which one? So we're moving forward with that progression, but in a really small way where the child still feels like they have some control over it. The other 2 are just opportunities to talk about the food groups, what we're eating, what we need to eat, and just give a visual. Our language comes and goes really quick. I can say 5 bites 10 times, but when that visual is there of 5 bites, it stays concrete regardless of how long it's been. So considerations for feeding therapy. Start with building that trust, and that's going to be with a caregiver, with a child, and with a provider. Again, include some of those tools for reinforcement if needed. Talk about food and how the child is here to learn. Share your experience with your providers. It's always helpful to know where you have been on your journey, what's worked and hasn't worked, but also be open to revisiting something that didn't work in the past, but might now. So some of our strategies aren't necessarily, we might have used them a little too early in the journey, or, you know, a little too early in your child's developmental growth. And so don't hesitate, or should say, be open to going back to considering using them again. Avoid yes, no questions. Oh my gosh, it's so hard, but definitely, do you want whatever? It's probably going to be no. So always offer choices as much as we can, because those perceived choices, you know, if I say, do you want to, you know, hold the food in your teeth? They're going to say no. But do you want to kiss it or hold it in your teeth? Then it gives them an option to have a choice. When we have choices, we feel like we have some control. Teach the child a way to communicate if an expectation is challenging. Sometimes kids don't have that language. They just get really upset. So it's okay to say, hey, that looks like it's really hard for you today. Maybe we should just go back to smelling it today. Don't push through if it's going to cause more behaviors. Don't hesitate to back down and be like, okay, next time we're going to start somewhere different. And that's hard today. We all have this. What's easy one day might be hard the next day. So often kids will, you know, take a bite and be like, oh, I really like that. But then the next day you give it and they're like, nah, don't like that anymore. So you might have to keep going back and forth between some of those tools until that becomes pretty consistent. So here's some of the challenges that we see, but I have talked a long time and would love to open it up for questions. So instead of me providing questions that we might see, I would love to hear from any families, questions that you guys might have.
Kristen, we do have one question in the chat. Taybi is asking, what are some ways to step down the grazing? Would it be something like stepping down to 3 meals and 3 snacks, or something else?
That's a great question. So sometimes it always depends on what those grazing patterns look like and the age of the child. So yes, those 3 meals and 3 snacks would definitely be the best opportunity. That doesn't always work for every child. So if the pattern is that the child just goes and gets the food whenever they want, and you've had the kitchen open all the time, sometimes I'll put, again, I'm very into visuals, so we don't always have to have all the auditory. Maybe a red circle will go on the pantry, and 20 minutes before a meal to start with, the red circle's up. Hey, the kitchen's off limits. We're going to eat in 20 minutes, for instance. And so we then take that to 30 minutes before and 45 minutes before until we get a wider period of time in between those meals. So that's one strategy depending on your child. And that might be that within that 20 minutes before the meal, the child never even comes and asks for a food during that, period. And that's okay. But it just gives that visual of, okay, we're not going to have anything right now. If you are leaving foods out for your child to get that, then we just take the foods away in that same progression. 20 minutes before your next meal, we want to take away, then 30, then 45, then an hour, so that we have that gap. If fluids are the way they're filling up, then you can substitute with water. They're not going to be happy about substituting milk or juice for water, but water is always okay to have in between meals, so that opportunity can stand. We all have water throughout in between meals throughout the day, and we want to continue with that practice for our kids. If weight is see, this is where it gets a little challenging. So I'm going to speak in a very general, not knowing the foundation. So don't quote me on anything. But if weight is not a concern, it is, we're have a little bit more opportunity to say at 30 minutes, we're going to stop this meal and the food's going to go away. For some individuals, we do have to prolong it just a little bit more, but we really try to say, okay, I would rather stop that meal at 30 minutes and maybe have a snack a little bit sooner versus keeping that meal go for an hour and having a snack after that. I hope that answers some of them.
Yeah, it's great. Thank you. And Taby also shared a little bit more context, which you might want to address. They're saying that their son is 8 years old, at this point requires some help to get his foods, but they have a tendency to drop whatever they're doing to get him to eat to avoid tantrums, and he only eats certain foods made specific ways.
Yeah. So that is challenging if the response is that tantrum, and that's why we try to make sure that there's not a long time in between the next one. So what it might be, the behaviors are big. Sometimes you can ignore them, and that's the best thing to do is just turn around. Sometimes we just say, hey, right now we're going to have 5 crackers, for instance, and try to start to change that pattern in that way by limiting the volume in which you're doing. Sometimes it's setting a timer, like time timers for families that have them are great. And that's because it's a red timer that kids can visually see. And so using a timer and maybe just setting it for 5 minutes. Hey, I hear you're hungry. We can have something in 5 minutes. So maybe that is your next best step, is just not having that immediate acknowledgement, but being willing to say, hey, in 5 minutes, when this timer's gone, then I will address that.
Awesome. Yeah, Dr. Wiley also added that to the chat, that a visual timer could be helpful to teach waiting, and learning to wait is a hard skill.
Thank you, Dr. Wiley.
Another question from Min says, what are some common anatomical reasons you see in RTS for feeding challenges? My child has silent aspiration and was recently diagnosed with laryngeal cleft. I would love to learn about evidence-based strategies for improving swallows in addition to surgical correction.
Yeah, so with the cleft, usually we go for that surgical correction. Most of the time, obviously that's up to your medical provider, but we do see that supporting that swallow function. What the aspiration is the timing of the swallow. And sometimes that is neurologically based, and sometimes that is anatomically based. And so if we're thinking that timing is off potentially because of a cleft, that's why a lot of medical providers will say, yes, let's repair that cleft and see if the rest of the flow and timing of that swallow is supported. So to answer your question from a therapeutic standpoint, what we want to do is modify those liquids, tend to be the most challenging, modify those liquids in order to have a successful timing of that swallow. Because we're teaching, it's like riding a bike, you get on, you do this, you start to learn, and you keep going. Well, if my body has a poor timing and I just keep practicing that over and over and over and over, you're going to continue with that poor timing. But if I can modify those liquids, make them a little bit thicker, change the flow of what I'm using to drink out of, maybe it's an open cup versus a sippy cup, or maybe it's a smaller nipple size versus a larger nipple size. All of those environmental modifications give the child more time and opportunity to better support that swallow function.
Awesome, thank you. Anastasia has a question, and then Helen, can we have your question next? Or was your question regarding what Dr. Turner just was talking about? Okay. Anastasia says, my 6-year-old can't just sit and eat. She wants to eat, run, and jump, or do any activity like painting or pretend play while having her food. It can take up to an hour to finish her food, or I have to feed her. Do you have any suggestions?
So I think I would use a little bit of a combination for these kids that need to move. And again, just because it's so fresh, in my mind, but when I was working with psychology today, her strategy was to do 6 bites and then there was a break and a timer was set for 30 seconds and we came back and we did 6 bites. So some kids just really need to move right now. And so having this number of bites for my really distracted kids, sometimes a fill and empty of the plate is just the best. You literally put 6 pieces on there. When that plate's empty, they can get up and move, but it gives them a really good motivation to make that plate empty, set that timer and come back. And you might have to use a visual to be, again, I'm going to use the Connect 4 checkers, for instance. Maybe you put 5 checkers down and you get to do that 5 times. So when you come back, you put one of those checkers in. Oh, we're going to do this 4 more times. You can build volume from those successful routines. So it might be that you have to start out with 4 or 5 bites and they get down. The child might come back and you can have 6 or 7 bites and then they get down. So build volume from the routine that's successful. And that way you're still giving that child that movement opportunity, but yet you're getting just enough time to sit and interact, and you're having some control over that situation.
Right. Great questions, everybody. Helen, would you like to share your question next?
Yeah, sure. It's actually affirmation. And where were you for me, Kristen, many years ago? But I have an adult son now, and we've just had to go with the flow. And so his eating is puree. He'll eat anything so long as it's soft. And also, we have a DVD playing and that he is prepared to watch while he's eating. It's the only solution we've had, and he's fine outside of the house. It's a routine that's been learned, and we can't unlearn it because he's severely autistic, as well as his RTS. But yeah, it works well. So I've just offering a suggestion of pick the battle, and because my son eats pureed food and he's still on a sipper cup at 32 years old, it still works well, and he's thriving in his dietetic. In his environment. He's got a lot of other hassles going on, and he's on loads and loads of medications. So that's given while he's eating as well. But yeah, it's just about picking the battles, and it worked for us. But Kristen, your advice would have been really helpful many, many years ago.
I also
So
appreciate that insight and input. And I have had to tell multiple families, again, you recognize that there's a barrier, but there's so many other challenges that you're managing. If you can get that nutrition, you have that growth, and you have everything you need, maybe this is what is working for him, and that's okay. It doesn't always have to look like the norm or the typical. So recognizing as a parent that that's not a failure, that's a choice, and that's okay to make that choice. Society has made feeding such an integral part, and everyone has an opinion and a suggestion on it, and yours might look different, and that doesn't make it bad. It's just different. So thank you for sharing that.
Yeah.
And I'm going to go get
my son won't do. Yeah, and he won't do. He has high palate, and so he stores up above the palate and then does bulk swallow. So the chewing is just out of the question for Ben. He's got unusual teeth and gums. Yeah, so as I said, pick the battle. Puree works well, and all the staff are trained to do it, and it just works well.
And that's perfect. Okay, I'll be right back.
Ben won't even eat sweets, so that's he won't even eat a sweet, anything that's hard. Chocolate, out of the question. Chocolate's my favourite thing, out of the question for him. So it's all puree soft. He'll eat a sandwich cut into really small bits without crusts, with a soft insert, a soft, a peanut butter or a honey or a banana or whatever. There's always soft and small.
Well, you've done a great job finding what works for him. So kudos to you for supporting him.
All right. Our next question is, we were recently diagnosed with RTS. My child is not picky and eats pretty well, but does not gain weight. He is 11 next month and 49 pounds. He does not want mushy foods and absolutely will not use utensils. He does seem to choke on foods occasionally. I believe he has issues with that. We're in Columbus, Ohio, and we would travel to Cincinnati. Which doctors there would be best to see for food sensitivity, allergies, and swallowing issues? What type of doctor or therapist would I see for the utensils issues? He does have a complex health history, but nationwide here does not seem very concerned with any of my concerns, and the couple I mentioned are only a couple.
Given the diversity of some of those questions, I would probably, within Cincinnati Children's, go to our interdisciplinary feeding team. So within that team, you're going to get nursing, our dietitian, speech, OT, and a GI provider all within one visit. So I think that would best support truly understanding all of the medical background, as well as those oral motor skills from both an OT and speech standpoint. So that observation happens with both providers. So we get a little bit of that self-help skills questions are going to come into play, as well as understanding that sensory, oral motor, and nutrition from the growth. So you can get a referral from your provider to our interdisciplinary feeding team. That would be my recommendation. And maybe I'll get to see you.
Thank you. And we don't have the name of that person, but Celia added her email address to the chat. If you want to reach out to Celia, she can help you get connected. So another question is saying, my 3-year-old can only bite some food but doesn't chew. She can only swallow some paste type or like mushy food. How can we make her learn to chew? She might bite a piece of cracker but will spit it out finally, never chew and swallow.
So 3-year-olds and feeding are one of the most challenging ages, I think. So it is part of, growing and learning with your child. So deep breath and patience. It is really hard at this age because there's not a whole lot of give and take and understanding. They pretty much do what they want to do at 3 across the board. So one of the things that I like to do just to start to really work on that chewing is maybe they're called Nook brushes, but there are different other chewy type tubes, and dipping them in one of those paste items that she will, and just holding it on those molars to get that chewing pattern. Again, think about the sensory characteristics of food. Every time you put a food in, if she bites off, it changes so fast that that sensory response often is to spit it out. But if I have a chewy tube with a puree that I dip in and out, it doesn't matter how many times I munch on that chewy tube, it's going to stay the same. And I can take it out and dip it in puree again and put it in, and that chewy tube stays the same. So we can work on that skill of that munching pattern and that modeling with that munching pattern without having to worry about the sensory characteristics of the foods being presented. So you might just start there. And then the foods that you are presenting, just think about things that are a meltable solid. Can I add water to it and it starts to dissolve? That's a great way to say, okay, saliva alone is going to help support. So even if our chewing skills are not mastered, you're still having that opportunity to do that bite and have a different texture in your mouth.
Excuse me, it's my question. So sorry, the information on the screen is not my name. You can call me Jeff or Liquid. Because the problem is the little girl, you're talking about the chewing tube. It's kind of a tool, right?
Is a tool, yes.
Oh,
Yep.
okay, chewing tube. I never heard of this term before. So
Yeah, so there's a couple, you'll find them on Amazon. There's ones that are in the shape of a P or Q, and it will just say chewy chew, but they'll have just a little stick to which she can hold it and just bite on.
Oh,
Some
okay.
kids use it for sensory exploration, like they just love to have toys and things in their mouth. And so we'll use these chewy tubes for them to have something to bite on. But I also like to use it when kids are practicing skills because it's a tool that I can hold on to and have them model. There's also ones that are like in the shape of a T. And when you do that, you can hold it on these molar surfaces where we expect to do some of that chewing.
Okay. Currently, so before, so when we fed her, we had to play a toy with her and read books. Only at a specific page of a specific book, she may open her mouth. We can feed her a bite. Otherwise, she won't. But later on, we change our strategy. So we begin to show her some cartoons using an iPad. So when she eats now, she has to watch iPad. So I know too much screen is no good for young children, but we don't have any other options now. At least now we can make her eat. Although, she throw out very often, but at least now she can eat. But only one kind of food, the soft noodle plus ground pork plus ground or minced potato, sorry, tomato altogether. For 2 years already, that's the only food she can eat. So pathetic. So I don't know what to do. So she doesn't, for the solid food, she doesn't chew. She can bite a
Yeah.
piece of cracker or something, but eventually she will spit it
Which
out.
immediately pushes out. Yeah.
Doesn't
Yeah.
doesn't doesn't chew, doesn't swallow. Anyway, okay. I'll try what you're
Yeah, I
suggesting.
think you're doing some great things. One of the things that kids that really need those electronics, again, we are all in different situations because there's always a reason, there's always a foundation in how we got to these situations. And yeah, if your, child needed to eat and screens how that happened, then that's okay. If we want to pull away from that, I just do a really quick pause when you're giving the bite and then immediately play. So, what you're trying to do is make your child have an active eating moment where the screen is not in front of them, but that bite is, and it happens so quick. And then that pause can start to potentially lengthen out. But in order to make changes, we need our kids to be active eaters and at least have some recognition of what's in front of them. So I would try the chewy tube and maybe that quick pause to see if you can get just a bite in, and maybe it's only for 5 bites. Again, small change in whatever you're doing with that pause, and then the rest of the meal you just continue as is.
Okay, great. Thanks. So I never tried that. To pause the screen a bit, so to make her to make the
Be
environment
quick.
change a
She's
bit.
not going to be happy about it. So have
I
that
know.
bite ready.
I know she'll be very mad.
Yes.
Thanks. Thanks a lot.
Sherry had a question. Kristen, do you know how common swallowing or aspiration concerns are for infants with RTS? And when should a swallow study be considered?
Great question. I don't have any statistics about about the incidence of aspiration and children with RTS. Typically, we refer for a swallow study when we're seeing clinical signs of challenges, and that would be I'm drinking, and then I have coughing after. And this happens to you and I, if you take a big drink of something, you start coughing. And truly, we say that went down the wrong pipe. Well, that's exactly what happened. But our bodies cough and push that liquid back out. So a cough when eating, or eating and sounding almost wet or congested, like they need to cough. Those are 2 clinical signs that there might be some swallow challenges. You can at times see kids just stop eating. They self-limit volume because of swallow challenges, and we don't always have those external clinical signs to know that. But some kids do that. There are lots of kids who have silent aspiration, so we don't have all the clinical tools to understand that. But the majority of the time, you can hear some random coughs or some random congestion, and that would be your cue to do it. We don't do swallow assessments on every child. It would just, you are exposing your child to small volume of radiation. So we want to make sure that it's medically warranted to do a video swallow and that there are reasons or concerns already from a clinical standpoint.
Great. All right, I'm trying to get caught up in the chat. A lot of engagement and discussion, which is awesome.
Yeah,
Do you have any?
I just like put a little thing in about the RTS guidelines. There's not really great data on frequency of aspiration, but feeding problems are very common, and G tubes are, I think they like said something like 30 to 40%. So not to say that that means they all aspirate, but it definitely is a big concern. And I think the idea that there can be anatomic reasons is at least something to recognize if therapy or progress isn't going well, or if there's a lot of respiratory illnesses that would suggest maybe things aren't going in the right pipe.
Thank you, Dr. Wiley. And I think, as families are going on their journey, and I know in my early clinical experiences, I was like, oh, no G tube, no NG. Like it was very scary for families. It's, can be very scary as an early provider. But now I have such a great respect for the opportunity we have to give our children nutrition and take off some of that stress. And, I have conversations a lot with families because sometimes their ongoing clinician is the one they trust the most because we spend the most time and have, really invested in their journey. But it's okay to use that support and takes off so much for the family. My goal is always still to be as oral as the child has the skills for. And again, what that looks like can be very different, but it is very nice for children that have strong either sensory or oral motor or swallow dysfunction to have the opportunity to engage in a social way without the stress of having to get volume in. So
Great. Kristen, do you have any tips for progressing beyond soft foods and dissolvable solids towards things like breads, pizza, tortillas?
So depending on your child, breads and pizzas and tortillas can be, I know those are just examples you're throwing off, but just to think about some of those foods tend to get really sticky and gummy and can be hard. So if I'm trying to move to a bread, sometimes I will have families lightly toast it or taking rolling pin and even roll it out so it's thinner than typical. Same with tortillas. We need to give it a little more oomph or a little bit more texture, not texture, a little bit more flavor. So think about what can I spread on those items to give more of that input. So all of those can be helpful, and then very small sizes, small bite sizes.
Right. Great suggestions. Thank you. Celia and Ilka, if you want to let me know if I missed any questions in the chat, I don't want to leave anybody hanging, but I did want to make sure that we had a couple minutes to wrap up, and obviously thank Kristen so much for your presentation. It was super informative, and your time answering questions and being extremely thorough. Very much appreciate it.
Well, thank you guys for having me again.
Yes. So for our upcoming events in February, we have another of our, every other month we're doing a social group for young women with Rubinstein-Taybi syndrome. We are opening this up to women and girls who are ages 21 and up. So if you have someone that fits that demographic who is not on our email list, please reach out and we will get them added. We would love to see them. In March, we'll have our next speaker series with Dr. TJ Nestide about addressing behavior in individuals with Rubinstein-Taybi syndrome. So I'll be sending out a flyer soon. Just another heads up, I hope you got my email, but we have a YouTube channel. Here's the link and here's the QR code to get to it. And this is where we're posting our recordings for our Rubinstein-Taybi syndrome virtual speaker series and some other resource videos. So that's a really great place to check out what we've been working on. And last but not least, like Celia mentioned, if you could please fill out our survey, just to give us feedback about the event tonight. I'm also going to put it in the chat. Just gives us information about how how the presentation went and how we can move forward, and also letting our stakeholders know, who our information reaches and how you're planning on using it. All right.
I want to just say thanks again to everybody. And Lauren, I checked the chat. I don't think we missed any, but I will go back and I'll download it and make sure there's no unanswered questions. But I want to just give Lauren a round of applause for that YouTube channel. We've been wanting to make that happen for a while. And this woman is magical behind the scenes, and more and more time she has done something incredible. So that's going to be a great resource. Please share it out to others. We'll get it onto some of the Facebook pages too, but we're super excited. So thank you.
Yep, I'm doing the same, Celia. I've spread it far and wide. We've got an Australian Rubinstein-Taybi group as well, and it's just been so helpful to many. So thank you so much.
You're always so brave to come so late at night. Now they'll have another option. I'm afraid I'll miss seeing you. I hope you keep coming.
It's awesome. It's a great resource.
How do we do the survey? Sorry.
Oh, no, that's okay. So if you want to use your phone to scan the QR code, or in the chat, I'm going to add the link to click on to take the survey.
That'll be great. So I'm not very good at scanning things. So
okay, yeah, that's what I was, wanted to give you the option as well. So let me copy and
And
paste
Lauren,
that.
people wanted
Yes.
to know what the name of the YouTube channel is. Like how would they find it?
So right now you kind of have to find it by going to our USAID website and then going to the YouTube channel from there.
Could you
Is
put the
that
link? Do you think you can put the link in the chat? Do you think you can go there real quick and get that link and put it in the chat?
Yes.
Trying to.
That would be great.
Yeah, I actually have it pulled up because I thought that might be
Okay,
helpful.
super. Thank you.
Absolutely. Okay, so I have the link to the evaluation and link to the YouTube in the chat. Alrighty. Well, thank you everybody so much for coming. Good to wrap up and say goodnight.
Thanks, everybody.
thank
And
you.
thank you again,
Thank
Kristen.
you very
If
much.
there you are. Thank you.
Thank you.
Hopefully you'll get
Thank
out before it
you.
gets dark again, Kristen.
Oh, good one.
I'm
Thank you,
hoping
Dr. Wiley,
so.
for stopping
Sorry
by.
about
Thank
that.
you. No, I love that. It just makes us all a little bit more human. I appreciate it like that.
Don't present in your basement is what I just learned.
There you go. Well, when we're tapping into you at 7 o'clock at night, I think it's